And so today, this session is really exciting. It's with Peter Speyer of IHME, and it's on global burden of diseases, analyzing and visualizing big data in global health. And so just a little bit about him, although there's a lot to say. He oversees the areas of data seeking, data management, data sharing, and data visualization, with studies spanning all areas of global and public health on a global scale. Peter's team stays busy in obtaining and managing census, survey, vital registration, health record, and administrative and other health-related data from around the world to provide researchers at IHME with necessary input for their analyses. He managed the development and implementation of Global Health Data Exchange, IHME's public data catalog, and repository of health-related data, as well as the development of innovative GIS and visualization platforms.
Well, thanks, Diana. Thank you. So welcome, everybody, to this Global Health session. It's a casual group. If you want to move in closer, or while I'm speaking, interrupt with questions, since it's a smallish group, I'd be happy to answer those. As Diana said, I'm Peter Speyer. I work with the Institute for Health Metrics and Evaluation, and I'm going to be talking about our current flagship project, the Global Burden of Disease. We launched actually the first set of results from this project in December in London, and there was a live broadcast event and a lot of visualizations and videos on our website. So if you had a chance to check those out, you know some of the things I'm going to be talking about. My role at IHME, as Diana said, is mainly focusing around data seeking, data management at the organization, and then disseminating the results of IHME. So today's talk is going to focus on these aspects of global burden. So I'm not going to do a deep dive on what are all the results that we're seeing. I'm going to show some of that. And I'm going to focus mainly on kind of the underlying data work and the challenges that comes with trying to analyze on a global level health-related data. I've been with IHME for about 4.5 years. Back then I was a newbie to global health. I was prior to that in media and tourism, and then wanted to do something more meaningful and joined IHME and have grown to love this area a lot. So you'll hear the excitement about the work that we're doing there. I'm German, moved here 8 years ago with a firm plan to move back after 2, and I'm still here, and you see the reasons why kind of right outside the hall here. So to dive in, I'm going to talk today briefly about IHME and who we are, although show of hands, who knows IHME and what we do? That's almost half. That's good. Well, it's a local crowd. I'm just going to do a quick brush over it too. Introduce the global burden of disease study and the work that we've been doing, but then dive into the challenges with the data in terms of how do we find, manage, and analyze the data for the global burden of disease, and interpreting and visualizing the results. I have quite a few interactive visualizations. I'm going to try to leave a lot of time at the end to actually play with those, and then you can ask questions and we can try to investigate a little further into the data and give you a brief outlook of what's happening next with GBD. So IHME is a research institute at the University of Washington. We are providing independent insight, which is a key differentiator for IHME compared to a lot of UN and other research organizations that have either funding activities associated or are responding to member states. So IHME was created with the purpose of providing independent measurements of global health trends. And what we're trying to do is improve health around the world with better evidence for policy and decision makers to make the decisions with. We have core funding from the Bill and Melinda Gates Foundation in the state of Washington, but then we also apply for specific research grants from NIH, NSF, and other donor organizations. We were created about a little over 5 years ago, and have grown from about 3 people back then to 140 now, and we're still on a growth trajectory. So it's quite a sizable group. About 80 of the folks there are academic researchers, professors, lecturers, and we have a large post-bachelor fellowship program as well as a postgraduate fellowship program. And then 60 are staff that are doing various support roles, from strategy and communications to admin and ops training, and what I'm doing, the data work. What IHME is trying to do now and in the long run is trying to answer 3 big questions in global health. The first is, what are the world's health problems? Trying to understand, what do people suffer from, what do people die of, how healthy are people? And GBD is our main contribution to that for now. The second big question is, how well are we doing addressing these problems in terms of performance of health systems, delivery of interventions, financing of health? We have an annual report kind of showing how much international aid flow go into health, and how is kind of health financed and supported. And then the third question, which we have started tackling a year ago or so and are basically building up the work, is to provide decision makers with tools to better allocate resources limited resources in most countries, to address health problems. So it's a pretty broad research agenda. We do about 75–80% of our work on a global scale, so trying to compare countries amongst each other and doing deep dives in countries around the world. And about 25% of our work is US focused, and we do quite a few projects in Washington State and King County specifically, where we try to drill into way more detail. So we're kind of going from high level view, which I'm going to show you in GBD, all the way to kind of local trends and patterns. So let's jump into global burden of disease. So what is this project? And I'm going to read this because it's very concise and it captures basically everything we've worked on for the past 5 years here. It's a systematic scientific effort to quantify the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, and geographies for specific points in time. There's a few key things in here. One is it's systematic. So we're systematically looking for all the data we can find, systematically trying to use models to do our estimation in a comparative way. It's scientific. The methods that we're using for GBD were published in a triple issue of The Lancet in December. We took over an entire issue of The Lancet with this paper. And we're trying to quantify health loss, both from mortality and from morbidity. And we're trying to do that on a very granular level in terms of age group, sex, and then over time. There's 4 key measures which I'm going to come back to time and again, and some of you might know this already, but I'm going to go through anyway. One is we need to know how many people die in the world in a given age group and in a given year, and we need to know what causes they died from. So that's the first big contributor to burden. Years of life lost basically counts all the years that we're losing with every death compared to an optimum life expectancy. While these are years lived with disability or lost due to disability, so measuring when people get sick, how sick are they, how long are they going to recover, and then quantifying that. And then while else plus while these, it's a simple sum, give you disability adjusted life years, and that's basically the quantity that we use to measure global burden of disease, and with which we then can compare burden by disease, by injury, across age groups and across countries. Feel free to interrupt with questions if anything of that is unclear. Why are we doing this? A multitude of reasons. Basically, we're trying to create evidence that helps people make better decisions in health, be that planning purposes, be that resource allocation, be that tracking how well we're doing addressing these health problems. Are people getting sicker? Are they getting better? Which patterns do we see in the data? We want to inform policymakers, donors, global agenda setters, and others. So we have a very broad audience that we want to reach with these data and that we create these data for. And as I go through kind of the detail that we have and how we communicate, would love to get some feedback on how well you think you understand what we're doing here and how well you see that kind of apply to anyone from a researcher in a very sophisticated setting that knows a lot about global health, all the way to policymakers or the general public that wants to know about global health, but basically doesn't know all these terms, but should have an understanding of what really ails the world. So the Global Burden of Disease Study 2010 that we published in December is based on work that has happened over the past 2 decades. It was started by Chris Murray, who's now the director of IHME and basically head of this project. But he and Alan Lopez, who's now at the University of Queensland, they're like the fathers of GBD. They invented how do we measure this, they invented the metrics, and basically have been involved with this effort over the past 20 years. It moved from World Bank and WHO to exclusively with the World Bank, and now this project, funded by the Gates Foundation with a specific grant, was done in collaboration with the WHO and 5 other academic centers, including the University of Queensland, Harvard University, Johns Hopkins, Imperial College, and the University of Tokyo. So it's a very broad-based group of organizations that help pull together the information and the methods for GBD. In the end, on those 7 papers that were published, we had 488 co-authors from 300 organizations in 50 countries around the world. And IHME was a coordinating center, and we did a lot of the underlying computation and bringing all the results together. But almost 500 people were involved in the work at various points in time, lending data, expertise, feedback, and input to make all this come to life. Understanding burden. So I explained briefly what deaths, while else, while these, and so on are, but I thought showing a little chart kind of how those things relate and how we measure might help. So if you look up on the x-axis, you see development over time. On the y-axis, you see basically the health state. So the end of the green box at the top would be completely healthy, 100%, and the beginning of the box would be birth. Then you see a line for death and a line for maximum life expectancy. So basically what we're trying to measure is, when do people die and how many years do they lose as they die compared to what they actually should have reached. So for every age group, in every country in the world, we established how long, what's the longest life expectancy in that age group anywhere in the world, and everybody should have a right to live that long. So any year they die earlier than that would count towards the YLLs. So basically that's the health loss from mortality. And then the gray boxes, for periods of time during one's life, one is sick with various ailments that sometimes one recovers, sometimes one doesn't. But there's a metric we call disability weight that says for a specific disease, what's the health loss that you're experiencing. So I'm wearing glasses, I have a health loss of like 0.5% in a given year. So it takes me 200, if I live with this for 200 years, that's almost like a life year lost, right? And then you have other diseases like acute schizophrenia, which causes a health loss of 75%. So it's, you know, getting close to the one level. So that's the range, and every single ailment falls somewhere into that spread. And then you have a duration component to that as well, depending on how long you are sick or ailing from something. And so you get YLDs over time with the severity, and then adding the gray boxes and the blue box up gives you the dollies.
Who's my kind of,
Pardon me?
the weight? Who gives you a weight?
The weights, I'm going to talk about that later. We did a big survey, in 4 countries, household surveys and an online survey. We had 30,000 responses roughly, where we made people compare 2 different health states and saying which one is worse. And I took the survey. It's really hard. It's like, what do you prefer? Would you like to live with a splitting headache and that makes you lose control over your daily activities, or do you want to lose, 4 limbs or something like that? But it's like, really? So they're supposed to be, so basically you're trying to make people weigh different outcomes. And we did that in different countries to say maybe that's very different in like a developing country versus the US or so. But it's a surprisingly equal pattern how people kind of judge the health impact of ailments. And it's really just on your health and not on like income or economic perspectives. So there's a scientific basis. There's 220 health states that we provided disability weights for and that we then use to quantify. So GBD, it's big data. Big data is all the rage these days, and most people talk about the petabytes of data that come from astrophysicists or Facebook or Twitter feeds that just have per second updates and again run into the giga and petabytes. For GBD, it's not the petabytes. It's the diversity of the data you need to do this, right? We have the 4 metrics that I talked about. We're looking at 291 causes, and specifically at 1,160 sequelae, which is kind of the actual states that you're in based on a certain cause. 66 risk factors in 187 countries, 3 time periods, 20 age groups, 3 genders. If you multiply that through, you have about 60 million results right there, and there's a whole bunch more analytics underneath, right? So it's, given that we have very diverse data sources and a lot of results, I would say that's big data. So where do we get all these data? And that's to a large extent my job, which makes my life really interesting. So we're going to international organizations, WHO, UNICEF, UNAIDS, World Bank, and others, collect various data that are of interest for us, or compiling data from their member countries that are of interest. We're talking to pretty much every Ministry of Health in the world, trying to get their survey, administrative, and other data. We're looking at central statistical organizations, which, except for in the US, every country has a central statistical body that compiles statistics from all their ministries and government work. The US does not, so you can go to different agencies. It works for us, but it's kind of an interesting factoid. We work with NGOs to try to get data from NGOs. We do extensive literature reviews specific to risk factors and causes. We go to libraries, we check out books, we scan and digitize printed information, and then many others. It's just like a little snapshot. But again, if you multiply that by 187 countries, there's a lot of work contacting, working with people, and so on. I'm going to briefly go through all the data sources that underlie our analysis, and stop me when you think it's getting too boring. But it's an important piece to kind of understand where the information comes from and how much work it is to actually bring this all together. So we start with mortality, right? We need to understand how many people die in the world. And the most important source for this is vital registration. So in most developed countries like the US, every birth and every death is registered, usually with a cause of death. And so if the system is reasonably complete, then you can just say, well, I know all the deaths in a given country in a given year by age. It's very simple. Most systems in the world are not complete. So you have about 130 countries that have vital registration systems to begin with, and most of these are not complete. So for those where it's not complete, you need to kind of track back and see kind of what was captured, and can you actually estimate based on incomplete data, or do you use the other methods that I'm mentioning below? There's sample registration systems in some countries that cover certain parts of a country in a systematic way. And then we use household surveys. And questions like in those surveys that are asked from mothers, how many children have you had? How many of those are still alive? Based on the age of the mother and when she had those children, you can estimate roughly how many children die in a given country in a given year. Some surveys ask for detailed or complete birth histories, where they actually list all the children with exact birth and death dates, and that helps you aggregate and then again estimate mortality. And then for adults, there's sibling survival, where people are asked how many siblings did you have and how many of those died. And there's various methods that help you then extrapolate from the survey population to the entire population and come up with mortality estimates. And underlying that, you also, to come up with mortality rates, you need to know what population these deaths relate to. And so we use the UN World Population Prospects as kind of the data standard for that. So there's a lot of methodology that goes into just estimating deaths. There's no truth that you can estimate. All the numbers we come up with are estimates that are hopefully getting closer and closer to the truth. But there's no country in the world that really registered every single death. Causes of death is the next most important question. So once you know how many people die, you want to know what did they die from, so you can actually estimate burden by disease. And again, vital registration with medical certification is the most important source, again, for the countries where that's possible. A very interesting alternative that I had no idea existed before I joined IHME is verbal autopsy, where when a death occurs that has no certified cause of death, you go back to the family of the deceased person and ask a catalog of questions. What symptoms did you experience? How long was that person sick? Did you have a fever? And so on and so forth. And then based on these answers, we can develop algorithms that then deduct the cause of death based on the symptoms. And so we try both machine learning algorithms, and we try to have doctors diagnose. And by now, the algorithms actually outperform the doctors in terms of being able to predict the cause of death. IHME did a large study where we had a population where we knew the cause of death based on hospital diagnoses and lab work. And then we went back to the families and asked them still the verbal autopsy questions, so we knew the truth and we could match against that. And so we're still trying to improve being able to gather information from verbal autopsies, but it's a really important way of then getting information in countries where deaths are not being certified with the cause of death.
Was it a separate project?
There was a separate project, yes, which is still ongoing. It's called GC13 if you want to look it up on the website. There's also interesting questions that you can use for cause of death analysis in surveys. For example, about maternal mortality, where you, for deaths, ask was a person of reproductive age or was the person pregnant at time of death, so you can gather information from that. We use disease registry information. Some, like cancer registries, have actual mortality information in there, so we know how many cancer deaths there were. Some only have cancer incidents, so you can try and extrapolate how many people died, so it's not that straightforward either. We use hospital records, we use data from burial sites or mortuaries in countries where we're really desperate. And then police crime reports, again, for only specific diseases. So basically, whatever we can lay our hands on that will have information on mortality, we try to compile that. And if we have more than one source for a country in terms of that kind of information, it's ideal because then you can triangulate and see how those sources actually match up. The next one is disease epidemiology. So for those 1,160 sequelae that underlie the 291 causes, we need to figure out how many people get sick, are sick, how long are they sick, and then you can use the disability weights to come up with the actual YLDs. So again, literature review is our main source of information for that, where we look at studies that are on specific causes of sequelae in different countries. Case reports of certain diseases to governments, population-based disease registries, and a whole array of others. Hospital data are increasingly important for that, because as more people go to hospitals in developed countries, or with the lack of data, clinics are actually your best source of information for for morbidity in other countries. That becomes a very interesting source of information. What I haven't listed, but should have, there are demographic and health surveillance sites in many countries around the world where, especially in sub-Saharan Africa and Asia, where certain populations are monitored very closely with censuses and surveys, and then linked up with data from hospital visits from those people. So you have smaller populations in different countries where you have a lot of knowledge on both morbidity and mortality, and they're very useful data points to then try and extrapolate to entire populations. So that's disease epidemiology. Risk factors, it's a very similar list to epidemiology, also lit reviews, surveys. I'm going to go into risk factors and what we capture, but they range from alcohol, drug use to diet and others. So depending on what you're looking at, there's actually very innovative data sources that you can use. So for example, air pollution is a big risk factor, for example, in China, as we all know. And so satellite imagery can help estimate how bad is air pollution where, right? So that helps us kind of come up with estimates for risk factors. The FAO provides information on diet. Alcohol producers have interesting statistics on how much alcohol is produced in what country and how much of that is consumed and where. And it also helps you kind of triangulate how much burden those risk factors can cause, and so on and so forth. So we have a list of 66 risk factors, and every single one has like interesting data sources underlying. And as with everything else that I'm talking about, if you're really interested in one of these aspects, look at the Lancet issue from December or send me an email and I'll shoot you more information, because like each piece of analysis, it could be described in way more detail than what I can do now. Disability weights, I mentioned briefly. We had household surveys in 4 countries and an online survey where we asked people those comparative questions and then came up with the disability weights system. And I mentioned the range of weights. So how do we get these data? It's a lengthy process depending on what data we're looking at. First, you need to find what data actually exists, which is more difficult than I initially thought. But data are often collected and then they linger in offices and closets and websites undiscovered. So looking online, doing web searches, literature reviews, and so on help. Accessing the data is also for health not often trivial, because there's confidentiality, there's privacy, there's HIPAA in the US and other regulations in other countries. And then there's the sheer fact that people don't like to share data if they have them, right? Data are power and they want to publish, or a ministry feels strongly about keeping data to themselves because they don't want others to judge, and so on. So there's various reasons that you have to overcome to actually get access to the data. And in many instances that requires doing data use agreements or otherwise kind of collaborating and negotiating to actually get access to these data. And then once you have the data, they come in a variety of formats. Excel, awesome. Databases, awesome. PDFs, not so awesome. Books, horrible. So it's a wide range, right? But basically what we can get, we'll take in, and we're going to go through the processes of then actually compiling internal databases that have extracts from all these different sources in a way that can be automatically computed. So one thing I wanted to point out in that context is, given that we do all these data searches, GBD is just one of our major projects. We have, as I said, a pretty broad scope of projects. We've created a platform where we started first, when I started at IHME, created an Excel spreadsheet saying, hey, what do we have? And I listed those things. And then I asked people, hey, what do you want? And I listed those. And then Excel got a little too small for that, so I created an Access database. And at one point that got too small or too cumbersome to use. So we created a platform called the Global Health Data Exchange, which is built in Drupal, and it's a data catalog where we capture information about data sets. And we use that internally to manage data and give our researchers, point them to where they can actually find the data set. So if you're searching for malaria deaths, then it'll point you, for Uganda, it'll point you to the statistical yearbook where that data actually can be found. For external folks, we can't usually share those reports because there's copyright on them, or we have a data use agreement. But at least we'll tell you what is the data set, when was the data collected, where and how, and we'll point you to the organization that collected the data and should be able to give it to you. So we hope that as we publish this information, more and more people will ask for access, and at one point hopefully countries give up and say, okay, fine, have it, and hopefully publish it, right? So what you see is a screenshot of the GHDX as we launched last week, with much more navigation, better search, and some features that really help folks that are interested in health and health-related data find those data. So the big search box is where you should start and just type in what you need, and then you get search results with sophisticated filtering systems, and you can drill down into what it is that you want. Yes?
You said that when you search through that, you would choose like a country and a
Yeah.
Do you, though, internally bring all the data together itself?
So we have 80% of the data that is cataloged in the GHDX, and we don't bring it together. So we leave the data sets as they are in the files that we're getting and catalog that. And then as researchers roll through projects, they'll extract specifically what they want. Like surveys have hundreds of questions. And so we didn't go through the effort of kind of putting all of that in a gigantic database or data warehouse, where we let people pull out specifically what they need for GBD or other projects. And then we have a GBD database that has all the relevant data points, or we have a number of GBD databases that have these data points in them. So those then are kind of can be automated. But if you're going to go back and find something else from these data sets, you have to go back to the actual source. Yes. You didn't want to go, the investment would be huge to try and integrate that. It'd be awesome, but it would be, yes, not quite feasible. So that's a look at the record. So once you pick one data set, I picked a GBD results data set where we can actually share the data because it's our results. And it just shows in a relatively systematic way, kind of title, information about time and geographic scope. There's a summary that explains roughly what the data are. There's keywords attached and citation. We believe that if you want to work with data, you should cite the data provider. So make it very easy to just copy and paste a citation into your research paper. We have an ability to comment. People don't like to comment on data sets, it seems like. So that's been just lingering there. We're just waiting. We're still waiting for people to actually use that feature. So now that we have all the data and we have them cataloged, here's a little overview, and that's really very schematic and very much simplified to what's actually happening of the components of GBD. And I'm not going to go through every box. But basically, they're numbered from 1 to 16 and go through each of the steps from mortality to causes of death to disease modeling to risk factors and the results. A couple that I want to point out, though, is CODEM at the top corner, and I wanted to spend a little bit of time on analytics and methods we're using. Is that of interest? People want to, yeah? So CODEM is an approach to cause of death modeling that we developed over the past couple of years, where for cause of death we have quite a lot of data, right? Over time, we go back to 1980 in our cause of death database, and so we have a lot of data points for different causes. However, to develop the actual estimates and trying out different models, we have developed a new approach to do predictive validity, where we come up with several models that you could use to predict causes of death for a given cause in a given geography. And you use for that the actual cause of death data. You can use covariates, you can use regional patterns, and you can come up with various kind of constellations of that. So our researchers create a number of these models, and then they take the data that's relevant, keep 25% of the data out, and use the 75% to develop the model and predict the 25 and see how close we're getting to the actual truth. And we do that with various models, and we do that each 1,000 times. 1,000 times we keep a quarter out, estimate them, and then see how close we're getting. And then just based on how well these models are performing, we're picking the best model or combination of models to do the actual prediction. So there's a lot of sophistication going into just this one step of predicting causes of death. Another one that's interesting is caught correct, where in GBD, since we're looking at all causes of disease and injury, we can actually squeeze all deaths through the total deaths in a given age, country, sex group. So if you go around and you ask AIDS researchers and TB researchers and malaria researchers and cancer researchers, and you add up all those deaths, you're going to have way more than the number of people that actually die in a given year, right? So we actually squeeze and make sure that every death is only counted once. And it's one of the reasons why a lot of our estimates will be quite different from what disease-specific research will give you, because nobody else has really the possibility of squeezing things through this, what we call a mortality envelope, and kind of framing or putting borders in terms of our estimates. A very interesting other piece of research is DISMOD number 7, where we're trying to make sense of all the data on the incidence of diseases, prevalence, duration, remission, and mortality, and trying to make sense of all these patterns. How many people get the disease? How many people have the disease? How many die? How many recover? And how long were they sick, right? And so trying to fill in all this those components in the Bayesian framework and make the model make sense. So just a couple of examples of kind of the power that's behind these things. Again, there's way more to be said about the different other components. One thing I should note is that through all these pieces of analysis, uncertainty intervals are propagated. So every result in GBD has uncertainty intervals associated with them at the end for you to kind of see the confidence into the results. I just went through these comments on the slide. Here's an example of data points that we have from various sources on child mortality in China. So you see a number of VR data points in purple. There's census data that we use. There's an inter-census survey there, and a few other data points. And you see how, initially, how big the range is that the different data would give you. And then basically, our estimation models then take all these data points, take some as outliers and others to just indicate either the level or the trend, and then come up with an estimate. In this case, since the data are relatively homogeneous in terms of the trends, the confidence interval is actually not all that wide.
So how do you apply weight factors to those individual data sets then? Or is that just is that model based on all those points?
It's based on, so this model is actually based on all the points, I think with the exception of the blue ones. These here we mark as outliers because they're on a very different level, so we ignored those.
So all those different data types are all given equal weights then?
Yes. So here's another example, household air pollution in countries like Bolivia or Nigeria. You have preciously few data points to work with. And those are instances where either regional patterns or covariates, which can range from income levels, GDP, education. For some diseases, we used the number of sheep in a country or the number of pigs in a country, if that was relevant, to help predict the actual levels in a given year and come up with actual estimates. But then, as you see, the confidence intervals tend to get a little wider when you don't have data and you have kind of things informed by those regional patterns or
So
covariates.
are you actually extrapolating back to 1980, even though you don't have any data points there, or are you really,
We are, but so the GBD
you don't have
published data on 1990 and 2010. So we only have 2 data points, and we do have the full data, the full time series, but we're really focusing on 1990 and 2010. But even in the absence of data points, yes, we're imputing the entire data set. Every country, age group, sex will have an estimate. The confidence intervals just get very wide in these instances. But we think that it's better to base decisions on very sparse data and a lot of assumptions than to have no frame of reference at all. And so what we're trying to do then is sit down with country officials and say, look, this is what we have for your country. Are you aware of any other data that we should be including? Or if you don't, then that might be a good area to actually do some data collection to get a better understanding of these. So what are the key advantages of using GBD? And I just jotted those down. Last night there's certainly many more. Fully imputed results is one of them, right? You actually can work with evidence now on all quantities of interest in all countries. We're using consistent methods across all steps of the analysis. So all results, data points are fully comparable across time and across countries. So you can actually now compare the performance, you can rank countries, you can look at trends over time and so on. And personally, I love it because for visualizations, having fully imputed and comparable time series means you can do whatever you want with those data and show them in very cool new configurations. Every death is only counted once. I talked about that. And then we have uncertainty intervals for all quantities of interest. So visualizations for us, and I'm going to jump into those now, and we can start playing a little bit and answer questions about the analysis and the data. We started working on visualizations mostly for internal reasons. The data are so huge, both the input and the results, that it's very hard to then look at spreadsheets with results and validate, is that plausible? Does this make sense? How do different countries compare and so on? Then we developed visualizations to look at geographical patterns and kind of the relationship between causes within a given country. And then as we got more sophisticated doing those, we realized, well, that's very good for external audiences as well. They might want to play with the same things we play with and explore the different dimensions of the data. And so we create a number of tools. I'm going to show you the biggest one that will get published on our website on March 5th. You may have seen the announcement. There's going to be the country level release of results at the Gates Foundation with Bill Gates and Michael Young in attendance. So it should be a really cool event, and we're going to launch 8 different visualizations. I'm going to show you a couple of those today. So what you see here is a tool. I'm going to start with one visualization, and then we're going to go and compare and contrast different visualizations. On the screen right now, you see a glorified pie chart. And it's called a tree map. And it shows 120 causes, so cause groups. It shows the overall burden broken down into 120 cause groups. And the size of the box is proportionate to the percentage of burden that this cause causes. And at the moment, we'll use the metric deaths. You see on the left side kind of all the things you can choose from. You're looking at deaths globally in 2010 for all ages, both sexes. And you see with one glance that there's a really big blue box, which is non-communicable diseases. So you see ischemic heart disease, you see strokes, you see COPD lung disease, you see diabetes, you see on the right side a bunch of cancers, lung cancer, stomach cancer, and others. You see a red box, which are communicable, maternal, neonatal, and nutritional diseases. So all diseases that are not non-communicable. So they're all in red. So low respiratory infection is the big one, diarrhea. Preterm, this little box there with sepsis and others is neonatal diseases and HIV. And then the green boxes at the bottom are injuries. So basically, in terms of deaths, the majority globally is driven by non-communicable diseases. But now we can start looking at things over time and by age groups. So let's look. This is 2010. If we go back in time to 1990, you see that a lot more deaths were caused by communicable diseases compared to NCDs. And then if you go to 2005, you see it shrinking, and 2010 shrinking even further. You can also look at it by age group. So let's go back. This is early neonatal, means the first 7 days. And it's all neonatal diseases. That totally makes sense, right? Preterm encephalopathy, and sepsis. Then as kids get older, this is late neonatal, so the first month of life, basically. You see some infectious disease coming in, low respiratory, diarrhea, and others. This is the first year of life, and now you see congenital and some of the non-communicable diseases, as well as injuries popping up. And then as we key on, this is 1 to 5 year olds. You see injuries getting bigger, but also malaria causing huge burden, mostly driven by sub-Saharan Africa. 5 to 9 year olds, still a huge burden in terms of non-communicable, communicable, but a big burden in terms of injuries. And then as the kids get older, you see injuries taking kind of the dominant role. One should note that those are age groups where not that many people die compared to the very early and very late stages. 25 to 29, you see HIV coming up, again driven by sub-Saharan Africa, and injuries getting less important. And then as people age, now we're 40, 45, basically non-communicable diseases are driving deaths. 60, 65, 70, there's hardly anything left, but the cancers, cardiovascular diseases, lung, and others. So now we're back to all ages. So that is deaths. Now if we go from deaths to YLLs, and I told you that YLLs count the years that you lose with every death. So if you go there, you'll see the neonatal diseases becoming more important, because every death there means you're losing 80 plus years. And so it gets weighted towards children. But this basically shows you the burden in terms of life years lost. And so there's almost not an equal split, but it's definitely a much bigger role for communicable diseases. And then if we look at YLDs, we'll see a dramatic change in terms of what diseases feature big, right? So these are all the diseases that cause morbidity. And so lower back pain, unipolar disorders, they don't necessarily cause death, but they do cause a large burden in terms of morbidity and YLDs. And then you sum those two up, and you get back to DALYs, which combines the YLDs and the YLLs. So one view is to just look at the overall cause pattern. But then we said, well, we want to look at geographic patterns as well. So we added a chart type here. And now we can look at the tree map. We're still at global. We're looking at DALYs 2010 all ages. At the bottom now, we have a global map that shows the rates, DALY rates per 100,000 population for a given cause. So if we take, for example, HIV, you see how sub-Saharan Africa, and especially what we call an HIV corridor in southern eastern Africa is affected. If you take malaria, you see a malaria corridor through western towards eastern Africa, which are the most affected. If you look at interpersonal violence, it's very interesting how in northern northern South America, Central America, and then Southern Africa, as well as the former Soviet Union countries, show a much higher burden. And now we can actually do the reverse as well, right? So if we're really interested in this, and we're saying, whoa, the highest here is, sorry, let me try and select this, Colombia, then you see basically that pattern reflected in the tree map. And, well, we probably assume if we look by sex that males are probably more prone to violence than females, which actually turns out to be true, very true. And it's probably not the all ages, but it's the younger age groups. So let's say 30 to 34. And you get a very impressive picture as to kind of what are the main causes, drivers for burden. And I actually just for more impressive results, if you just look at deaths, that's kind of the dominating picture. And then you can compare, so if young male adults in Colombia die from violence and HIV, if you then go over and you look at South Africa for the same picture, it's still violence and HIV, just the roles are very much reversed. So now we can start interrogating the data and just look at different countries and relationships. So we can do, if you want to look at specific countries right now, we can do that. I have a couple more charts that I want to show you in this, but I think we have, we have a little over 5 minutes. So let's do a couple of questions here. Pardon?
Do you have Ukraine as a separate country?
Of course we have Ukraine as a separate country.
It looks like it's covered by Soviet Union or something, which is not there.
No, we have the current countries, the 2010 countries. So we didn't split up Sudan. So we don't have South and Sudan split up, but yes, we have the former Soviet.
It's probably the same color as Russia, that's why I don't see it.
Okay, so this is Ukraine. Okay, well now you're challenging me. Hang on, let's go to tree map at the bottom.
I'm just looking at the map and I don't see the different colors, so probably just because it's the same color and the same causes as Russia.
It's probably similar. It's actually very similar.
Yeah, that's why I don't see the difference.
No, it's actually the same right now. Sorry, that was.
Comparing Russia to Russia.
Yeah, that was your user error. So there you go. So you have Ukraine at the bottom and then Russian Federation at the top, and that's for deaths. If you want to look at DALIs, doesn't want to show us DALIs. But yeah, so there's different numbers. As I said, it's a prototype. Okay, we let it reload really quick. You had a question.
So this is going to be online or available soon?
Correct, yes. A much improved version, I might add. It's going to be more user-friendly. The controls are improved. The performance is improved. And so it hopefully won't get stuck on things like this. So yes, and that's March 5th. It's going to be on the IHME website. Yes?
Does the shade within each color type tell you anything? Like drugs is a darker blue than
Maybe I should have told you that. That's true. Yes, so right now you're looking at shading. That's the rate of change. So from 2005 to 2010, the darker the color, the higher the growth rate, and the lighter. So the lightest color is actually decreasing burden. And we have different other shading. So you can just look at proportion. So basically, the bigger the box, the darker it would be. You can just color it by kind of what's the cause group, the blues, greens, and reds. And then we have an interesting view of risk factor attribution. So right now, and that's actually the Russian Federation and Ukraine are interesting examples. So this shows you the tree map of the causes in these countries based on deaths, and then the contribution of alcohol to the burden in these diseases, which is just huge in the Russian Federation, right? And that's, again, that's 30-year-old males. Maybe that's not fully representative, and we should go back to both sexes and all ages.
Wait, how do you know that? I see you changed the risk factor.
Yes, and then here's the risk factor. Again, the next version is going to have that in a little more kind of obvious order, so you'll see what you're looking at right now. And then you can also look at developing versus developed countries, and you kind of basically, see can explore the differences. So there, IHD, for example, much bigger burden in developed countries and of alcohol through IHD than in developing countries. So those are the shadings. And we're going to have a shading in the new version for uncertainty. So you can also look at the boxes, and you see the darker it is, the more confident we are in the results, and you see which of the diseases we're not that comfortable with or confident in.
How would people use this? Like, so how would you make this? How would people use this data? I guess it would be mostly who would be using this data?
So we would assume it's policymakers, donors, people that want to, right now it's at the national level, right? So it's really only useful for people that want to do international comparisons. So Gates Foundation, I want to look at malaria, kind of where's the biggest burden, where are many deaths, what are the age groups that are most affected, how do individual countries compare, which should be my focus country, things like that.
I guess anyone who's raising money for any organization that's, who's focusing on something like Alzheimer's or whatever that may be, that they can go through, and you've taken all this data.
Yes.
And
you can compare it.
filed it all for them.
Yes, exactly. So yeah, any cause or risk factor interest group could use that to say, hey, look, we're much bigger than these other guys, so you should spend money on this, not on the other.
That's right.
Yes, and again, because it's comparable, that's the beauty in that. I think other researchers will like this to kind of get context, right? And then in general, like the media love it, right? We have shared that with a couple of journalists, and they're like, woo, this is cool. NGOs that want to find kind of new focus areas or focus countries. Actually, commercial entities, right? I can see payers or pharma companies saying, hey, how big a burden is, IHD in China? Is it a market worth exploring? So it's a wide range of people. The problem is that there's a lot of controls, right? And they're going to be a little better in the new tool, but it's still, you kind of have to invest a little bit in understanding what are the things I can change and how do I explore differences and what are the settings I can use for this. It's not everything is immediately obvious. So we need to figure out probably a way to have a tool with less controls that makes it easier to kind of see stories and stuff like that.
Pharmaceutical companies is obvious.
What?
Consumers of the
Well,
so if you want to know what to sell and where to sell, that's all.
so we did it for policymakers and funders, and then
Your
others will
company
use it
should use it actually to raise money
yes,
from pharmaceutical companies.
we should. That is true. So the visualization tools are going to be free for everybody to access. What we do in terms of sharing the data and so on, we need to figure that out. It's a very good point. Yes.
How are the visualizations built? Is there a separate platform that
There's
builds
a-
it, or is it homegrown?
It's homegrown. It's using a platform called D3, which is a JavaScript package, which has kind of like some of those pre-built types of visualizations, and then you can customize it to your purposes. But you need someone who can do JavaScript. Yes, and pretty much all our tools are now built in D3. We started experimenting with things like Google Motion Charts and some of those existing platforms, but they never give you all the controls that you need to kind of explore a data set of this depth.
Thank you.
Is this coming from a cube or something like that data itself to power this thing?
There's going to be, so right now this runs off of flat files. So there's like little CSV files underlying that have those different views. Like I think there was like 180,000 at the last iteration of this. In the future, it's going to be a database, so a little SQL database that it runs from. Okay, then we're out of time actually. So there's more functionality to that tool. There's going to be other tools that are interesting to explore. Let me just give you a little glimpse. Here, for example, we developed a way of visualizing just a rank list of diseases. So this doesn't give you, it does give you the size of the problem, but it's mostly to just get a quick view. What are the top 10 diseases in a given geography? For example, here, this is again globally, what are the top diseases? Low respiratory infection in 1990, dropped to number 2 in 2010. And you see the lines relatively quickly, kind of what are the big ones that grew or declined. So HIV, tremendous growth between 1990 and 2010. Others like measles, big decline. And you can, again, look at this. We're going to have this at the country level right now. This shows it by region. So things change around for different geographies. You can explore all the different age groups. So the 15 to 19-year-olds in Central Asia are suffering mostly from used to road injuries and now major depressive disorders. So And again, you can use all the metrics that I mentioned before, DALYs, while else, and it basically gives you all those different views. This is, I think, something that if you want to have a quick glimpse at kind of how important are things, this will help you and you don't have to go through as many iterations and controls. And then we have a number of other visualizations that you can use to kind of fully explore the data. So I highly recommend on March 5th to tune in. On the IHME website, we'll feature the event. It's a live stream for an hour and a half where we'll release those visualizations. We're going to demo most of those. Bill Gates is going to say a few words, and Michael Young will say a few words. So I think it should be a really exciting and interesting event. And if you have any questions, hang on, let me go back to the presentation. I'll put up my contact information. Feel free to contact me, and I'll send you more information, and I'll provide you more background.
Is Chris going to say anything?
He's going to be the main speaker. Yes. I should have mentioned that too, shouldn't I? Yes. Yes, Chris is going to do the demos and provide the background. And if anyone is knowledgeable of global health, it's Chris. So, thank you.